Hey guys, I thought we'd just go over some of the Module 3 meds. Some of the videos that we did don't go over them very well, so let's get started. Kind of be a brief overview. We'll talk a little bit about the pain and sedation meds, and then we'll talk about anaphylactic type meds that we would use during an anaphylactic type reaction. We'll talk a little bit about respiratory emergency medications, and we're really going to talk briefly about RSI because on the next class, on the first Tuesday that you're back, we're going to kind of dedicate a whole day to RSI. So in pain and sedation, we want to talk about all of these medications, and we'll kind of talk about them individually and some of them as a group. So this slide shows three of the big guns opiate-wise that we use. We have fentanyl, hydromorphone, which you might know as Dilaudid, and morphine. These are all opiates, and although you don't use hydromorphone very much in the field, you will see it used in the emergency room, so I think it's good that you're at least a little familiar with it. The first line is the equivalent dose, and the equivalent dose for each of these is basically the same. What amount of the medication causes the same amount of analgesia? So if you give 10 milligrams of morphine, the equivalent in Dilaudid is giving 2 milligrams, and the equivalent in fentanyl is 100 micrograms. So what this means is that fentanyl by weight is much more potent than the rest of them. And then Dilaudid is the next most potent, and then morphine. Let's just talk about fentanyl a little bit. Fentanyl usually comes in 50 mics per mil. It's pretty standard. You don't usually see different dosing for that. You might see a different amount of volume. So they might come in a 2 milliliter vial, it might come in a 10 milliliter vial. The normal adult and pediatric dose is about a half to 1 mic per kilo. The thing that's interesting about fentanyl is it has a really fast onset, and so you're going to see in the field the results of the analgesia pretty fast, and then the amount of time it takes for it to reach its peak effect is pretty rapidly too. It's 3 to 5 minutes. Then the other reason why it's nice in the field is because it doesn't last very long. And so you're looking at 30 to 60 minutes is how long it's going to last. So the reason why that's good is when you come into the emergency room, you don't have a patient that's possibly sedated and a lower level of consciousness for, let's say, the hydromorphone 2 to 3 hours, or the morphine 4 to 5 hours was their duration of action. Some of the considerations for these is, for all three of them, is respiratory depression. For all three of them too, you have to consider hypotension, especially when you look at the Dilaudid and the morphine. The fentanyl doesn't cause hypotension as much as the others. The last thing that I threw in the fentanyl considerations is rigid chest, and if you give fentanyl too quickly, so you administer it too quickly into the IV, you can get this rigid chest, and what basically happens is the muscles become rigid, and so you cannot breathe with rigid intercostal muscles, and so your patient might become apneic. It's really seen in the operating room because they're given much higher doses, and it's really only seen when you give it rapidly. So all of these medications, the dose I would give at the very, very minimum over 30 seconds, and I would be giving them more over 60 seconds, these medications. And you'll see people in the field, they'll be just pushing them in like 2 to 3 seconds. And the thing that happens when you do that is you're going to see the side effects manifest themselves much more often, and I think with more intensity. So you look at the Dilaudid, normal dose 2 milligrams for like a 100 kilo patient. We usually give 0.5 to 2 milligrams, and it's 15 mics per kilo that we give, or 0.015 milligrams per kilogram to kids. Again, it takes a while for that to show up. So when you're in the ER and you've given somebody some Dilaudid and they get no pain relief after 5 minutes, you just need to wait a little bit longer, because it takes a little bit for that to have an onset. Again, it can cause hypotension and also respiratory depression. One of the things about this medication is, since it comes in like 2 milligrams in 1 milliliter, it's really easy to give too much. You just bump the syringe a little bit, and you've meant to give a half, and you've now given 2 milligrams, and so that can cause, over analgesia and increased respiratory depression. The other thing about both Dilaudid and morphine is that they're sulfates, and so if the patient's allergic to sulfa drugs, you can see an allergic reaction from these medications, and so then you'd want to go to fentanyl if they're allergic to sulfa drugs. We look at the morphine. We know that morphine's not just used for pain, we also use it for chest pain associated with MI, and for patients having problems with pulmonary edema. And one of the bonuses of that is that the mechanism is it causes an increased venous capacitance, because you get some vasodilation on the venous side, and that reduces the preload to the heart and the workload on the heart. And then it also, in pulmonary edema, allows that increased venous capacitance allows for fluid to be pulled off of the lungs. So hypotension, it can cause hypotension, again, from that vasodilation. Also, it has a little bit of a histamine release, and so you might see some histamine, so the patient might get itchy, they might have GI symptoms, stomach ache, and in particular nausea and vomiting, so you have to watch out for that. And then again, all of these cause respiratory depression. So the dose for morphine is usually 2 to 10 milligrams for an adult, and in chest pain you usually start with 2 milligrams and then just kind of add 2 milligrams every 10 to 15 minutes to see if it helps the chest pain. So Ketorolac, it's also known as Toradol. It's an IV NSAID, so non-steroidal anti-inflammatory drug. And so if someone's allergic to NSAIDs like ibuprofen or aspirin, then you don't want to give this, because they can have cross-sensitivity. And the other thing too is that most asthmatics are allergic to aspirin and other NSAIDs, and so you want to be very careful giving this to an asthmatic. The normal adult dose is 30 milligrams IV. Some of the literature says 15 milligrams. Mostly in the emergency room I see them give 30 milligrams IV, and then they can get it IM, either 30 or 60 milligrams IM. It's a pretty good pain reliever. It's not an opiate, so you're not going to get respiratory depression. I would say it's very similar to ibuprofen. It's just in the given IV or IM. There is a pediatric dose. I don't expect you to know it. I think it's like a half a milligram per kilogram, but don't worry about that. The other thing that you see on in the National Registry, because they use it in other places, is nitrous oxide. We don't seem to use that in this region. It's just like the mix that they use in the dentist office, and some of the considerations about nitrous oxide is that the patient has to be able to administer to themselves. So basically they have to hold the mask up to their face, because what that does is, and they have to be able to sit up, because when they have enough analgesia, then their hand falls away, and you know that they've had enough. If you strap the mask to their face, or they're lying down, then they can get administered too much, and it can lead to respiratory depression, of course, which leads to hypoxia, and then seizures, and then coma, and then death. So we don't want to do that. Let's talk about sedation. These medications are considered sedatives. They don't provide any analgesia. although the patient may be more unaware of their pain. So we obviously use these as anticonvulsants when someone's having a seizure, but we're going to talk about that case later in another module. But this is about providing sedation to either a patient that is very anxious or combative, or if they're having, maybe they have a fractured femur and they're having muscle spasms, or maybe we want to sedate them for a procedure such as synchronized cardioversion or realignment of a limb when we're going to splint it. Well, then we could use these medications. And these are the three big guns. Midazolam, which is also known as Versed, lorazepam, which is also known as Ativan, and diazepam, which is also known as Valium. So again, these medications have an equivalent dose. And so 4 milligrams of Versed is the same as 2 milligrams of lorazepam and 10 milligrams of Valium. So those are the equivalent doses of each of those medications. And then their normal adult dose and pediatric doses kind of reflect that. So normal dose for Versed, 2.5 to 5 milligrams for an adult, 1 to 2 milligrams of lorazepam, 5 to 10 milligrams of Valium. Where you really see a difference is in the onset, peak, and duration of these medications. Out of all three, the most reliable onset of action is with Valium. Valium's onset is usually 1 to 5 minutes, and the peak is within 15 to 30 minutes. And so when you're in the hospital, when they're using a medication for, say, a excited delirium patient, the Valium is probably the most used one, because if you see no effect after 5 minutes, you can give another dose. If you see no effect after 5 minutes, you can give another dose. These other medications are a little bit more variable. You can see in the Versed column that the onset is pretty rapid, 1.5 to 5 minutes. The peak is considered rapid, and the duration is 2 to 6 hours. I can tell you that usually you'll see it wear off closer to the 2 hours, and maybe even less than that, depending on your patient. All of these medications can cause respiratory depression, and in some cases they can cause hypotension. And so again, these are good patients to have on the end-tidal CO2 monitor when you're giving them these medications for sedation. They all cause varying degrees of amnesia and retroactive amnesia. So when you give these medicines, the patient may not remember the incident or anything you do after you give them the medications for a while. That's not 100%. Sometimes the patients remember just fine. So we never want to give these medications as something like, hey, we want them to forget what just happened or what I just said to them. Let's give them some Versed. That's not how these medications work. That's not how we're supposed to give them. We just give them for sedation or their anticonvulsant uses. The other thing is that the lorazepam and the diazepam are oil-based medications. The midazolam or the Versed is a water-based. So if you look on the side of the lorazepam, it says you have to dilute it 1:1, and a lot of times you don't see people do that, but you should do it. You should do that. You should dilute it 1:1. So usually you dilute it in however much volume you're giving. It comes packaged 2 milligrams in 1 milliliter. Then you should dilute it with the same amount of like normal saline. Diazepam, on the other hand, usually you don't dilute diazepam, and if you dilute it into very much normal saline, or you're giving it slowly through an IV line that's running, it will start to precipitate, and so you'll see it kind of just turn white, milky white as it's going in. And so that's something you wouldn't want to do either. You just want to administer it in its fully concentrated form when you give diazepam. You can see lorazepam it has a less of an onset, or more. It takes more of an onset, so 15 to 30 minutes is what I'm trying to say. There goes my phone. Okay, sorry about that. So where were we? I think we were talking about the onset of lorazepam being um, pretty long, and its onset and its peak is pretty close together. So it lasts a lot longer as an anticonvulsant than, say, diazepam does. Um, but in this case, when we're giving it as sedation, really Versed is the better one because it's going to wear off more quickly, and so you won't have the respiratory depression for as long. So one thing about all of those benzos is that they do not provide analgesia or pain management. So if you're mixing those with, say, you're giving fentanyl also, just remember that all of those kind of have a synergistic effect, and your patient can experience increased respiratory depression and increased hypotension. So make sure you're keeping a good eye on them. So here's some others that we're just going to talk briefly about. Ketamine, it's a really good drug. It has analgesic properties, sedative properties, and amnestic properties. The adult and pediatric dose for sedation is the same. It's 1.5 milligrams per kilogram IV. And if you have to give it IM, you just kind of triple the dose. It's 4 to 5 milligrams per kilogram IM. It's pretty rapid onset. IV, it's 30 seconds, and IM, it's 3 to 4 minutes. Some of the nice things about this medication is that it causes some bronchodilation. So if you have an asthmatic patient that you're going to RSI, ketamine's a good choice for that. It also doesn't make you hypotensive. If anything, it might give you a little bit of an increase of a heart rate, an increase of a blood pressure. And so it's good for pain management and people that have kind of marginal blood pressures that you're kind of, you're concerned about giving them morphine or fentanyl because of their blood pressure, and so you can give them ketamine instead. And I'm not talking about like MI type pain, but just other types of pain. There is a pain dose, and it's 0.2 to 0.5 milligrams per kilogram, so it's much less. And what you get there is you get the analgesia, but you don't get as much of the sedative properties. What ketamine does at the higher dose is it causes a dissociative state, and so it basically disconnects the brain from the body, and the patient becomes what we call disassociated. They're not feeling anything, they're not getting any sensory input, their brain just kind of shuts down. But a lot of times they keep breathing, and so that's the good part of it. It's also probably the drug of choice for induction in RSI when your patient is septic, because etomidate, that's kind of one of the things that you don't want to give when a patient is septic, is etomidate, because it causes adrenal suppression. So the etomidate we do use in RSI, unless it's a septic patient, and it's the same dose for adults and pediatrics. It's 0.3 milligrams per kilogram, and that's IV. And the onset is pretty rapid. Within 60 seconds, you'll see the patient go unconscious. It's a sedative, hypnotic is what it's considered. And this unconscious state lasts about 3 to 5 minutes. So sometimes when you give it, one of the side effects is myoclonic jerking. And so you might see the patient kind of jerk a couple times. And what a myoclonic jerk looks like is if you've ever been kind of drifting off to sleep and then all of a sudden your body just kind of jerks, that's a myoclonic jerk. And hypnotic medication, which etomidate is, just means that you're going to sleep. And so as they're going to sleep, sometimes they'll have those myoclonic jerks as they're drifting off. Those are normal. Some things that go along with the pain medications are antiemetics. These are medications that either slow nausea down or stop your patient from vomiting. They've typically, when we've used things like Phenergan or promethazine or metoclopramide or Vistaril, we've usually given those with the antiemetics because it potentiates, with the opiates, because it potentiates them. It actually makes them work better. And commonly with morphine and Dilaudid and Demerol, those things caused nausea in a lot of cases, and so we would give an antiemetic with it. So Phenergan or promethazine has been around for a long time. It's considered an anticholinergic, a phenothiazine. It has some sedative properties. The adult dose is typically 12.5 to 25 milligrams, and that's either IV or IM. The really big thing you have to watch out with Phenergan is that if your IV is infiltrating and Phenergan gets into the tissues, it causes necrosis. And there was a case of a world-class violin player that lost her arm because of Phenergan. And so physicians don't typically like us to use it that much anymore, or at least not as a first-line drug. Now we kind of use the ondansetron or Zofran as a first-line drug. So there is a pediatric dose, 0.25 to 1 milligram per kilogram. As with most pediatric doses, the max that you give is up to the adult dose. In your brain, you have this area called the chemoreceptor trigger zone, and there's 3 types of receptors there. There's the 5-HT3 receptor, which works off serotonin, the D2 receptors that work off of dopamine. Then I think the other one is the NK1 receptors, and I'm trying to think what they work off of. I can't remember what it is, but it begins with an N. Anyway, the Phenergan blocks the D2 receptor in the chemoreceptor trigger zone. That's what they think causes a person to feel nausea, whereas Zofran blocks the 5-HT3 or the serotonin receptors. When we look at Zofran, it's either given ODT, which is a disintegrating tablet in the mouth, or it can be given IV. The usual adult dose is 4 to 8 milligrams. When I've seen it used as a pretreatment for chemotherapy, I've seen people get 32 to 64 milligrams of Zofran. Ped dose is about 4 milligrams. So when we look at anaphylaxis, which is a severe allergic reaction causing shock-like symptoms, there's several go-to drugs, and of course oxygen is always going to be one of those. We want to make sure the patient has available plenty of O2. These patients typically end up on non-rebreather masks or being ventilated with a BVM with 100% oxygen. But epi is really our go-to drug for true anaphylactic shock, and we can give it one of 2 ways. We can give it either IM, and you can give it sub-Q, but I would just go IM. It works better and more reliably. And we can give it IV. Just remember that we never, ever, ever, ever give 1 to 1,000 epinephrine IV. We only ever give 1 to 10,000 epinephrine IV. So in the adult, we can give 0.3 to 0.5 milligrams of the 1 to 1,000 IM. And that's because the higher concentration of this drug makes it more rapidly available, since we don't have as good a circulation in the intramuscular compartment. Or we can give it IV, and the dose, depending on who you read, this is the one we're going to use for class, 0.01 milligrams per kilogram, not to exceed a half a milligram, or 0.5 milligrams. And again, this is the 1 to 10,000 solution. This is another drug that you should probably push kind of slow, like maybe give this half a milligram over the course of about 2 to 3 minutes. The PEDS dose, is 0.01 milligrams per kilogram, not to exceed, of course, the adult dose of 0.5 milligrams. Some places you'll read and it says not to go for 0.3 milligrams. For our class, we'll use 0.5. And there's only an IM dose for peds. There's no IV dose. And if epinephrine's not working for you, you're trying it, you can try an epinephrine infusion, run it at 2 to 10 mics, see if that helps. And then you can also move on to dopamine, and we're going to be given dopamine at 5 to 20 mics per kilo per minute. We also at the same time want to give some Benadryl or diphenhydramine. So this is a histamine blocker. In particular, it's an H1 blocker. We know that the normal adult dose is 25 to 50 milligrams, and the pediatric dose is 1 milligram per kilogram, not to exceed the maximum adult dose. So that in combination with epinephrine will help out. We have our histamine blockers. We actually have more than one type. If I remember right, there's 3. There's H1, H2, and H3 receptors. And so we actually can give medications that are H2 blockers, and the 2 most commonly ones are famotidine and cimetidine, and respectively these are Pepcid and Tagamet. And so diphenhydramine gets us the H1 blockade for the histamine, and then these others get the H2 receptors blocked. Typically won't see these carried on the ambulance. They have to be refrigerated, but you might see them in the emergency room. And then the last one is methylprednisone, and typically we're going to give 125 milligrams one-time dose to adult patients. I think in the book it has a lower dose for adult patients. I think the pediatric dose for this is 1 to 2 milligrams per kilogram, not to exceed the adult dose. Like I said, I think some of the texts say maybe 75 milligrams for the methylprednisone for adults. I know in the ER we typically give 125. We'll follow whatever the formulary says. So when we look at COPD has always been kind of viewed as a triad of diseases, asthma, emphysema, and chronic bronchitis. And you kind of get some of the same problems. The only difference between asthma and the others is that asthma is reversible. The others are not. So in all of these, you typically get some airway swelling, so edema, some bronchoconstriction, so the muscles constrict, causing narrowed airways, and you get mucus buildup. So when we look at asthma, there's several go-to medications also for this, and again, oxygen is being one of the first ones. And in this chapter in your book, chapter 14, it says what concentrations of oxygen each type of device provides. Pretty much we're either going to do a nasal cannula, which will provide up to 40 to 60, I'd say 40 to 50%. And then a non-rebreather mask, which will provide probably up to about 90% if it's a really tight fit, but not much more than that. We always hear about hypoxic drive and our COPD patients possibly going to stop breathing because of getting too much oxygen. It's very rare that ever happens, and I've never heard of it happening with anyone that I've ever met or worked with. So it's probably better to give oxygen than not give oxygen. Get their sats up around at least the low 90s. These people with COPD, emphysema probably live in the high 80s. So, you're probably not going to get them much higher than mid 90s. But again, our go-to medication for this is epinephrine, and it, of course, the beta 2 will increase bronchodilation, and it will also help dry up a little bit of the secretions, maybe take down the edema just a little bit. But the next one, albuterol, will also help with bronchodilation, and we know that's a beta 2 agonist. And then you have Xopenex. Xopenex is a form of albuterol. It's just a little bit cleaner. It's a they've taken off one of the isomers, and that isomer that they take off is pretty much the beta that you get in the albuterol, the beta 1. And so it's a pretty clean form of beta 2, so you don't get as much increased heart rate with the Xopenex. So it would be okay to use that. But really, if your patient's having trouble with blood pressure, say like with anaphylaxis, maybe, usually asthmatics won't have as much problem with blood pressure, but kicking up their heart rate a little bit with albuterol probably isn't necessarily a bad thing. Then we have an anticholinergic, Atrovent, ipratropium bromide, and that's going to block the cholinergic system, and the cholinergic system is what's producing all of this mucus, and so it'll start to dry out the airway. Now I put diphenhydramine on here with a question mark because it's kind of a trick question. You should never ever give these patients diphenhydramine, because what will happen is all this mucus in their lungs, as soon as you give them diphenhydramine, it will dry those out and turn them kind of into rock, concrete, very tenacious. They won't be able to move it. So it works a little bit differently than the Atrovent does. And so never ever give an asthmatic diphenhydramine. Mag sulfate, remember that this is kind of a poor man's calcium channel blocker, and so it relaxes smooth muscle, and so that can also help us relax smooth muscle in these asthma patients, especially if they're having a very difficult time. Methylprednisone will also help with the inflammation. Remember, along with anaphylaxis, I didn't mention it, but methylprednisone won't start working for a couple of hours, but the sooner you get it on board, the better that the faster it's going to start working. And it will help with the second phase. From learning about asthma that there's a first phase reaction, and then there's kind of this rebound second phase reaction. The treatment's pretty much the same for COPD emphysema. You probably don't want to go straight to epinephrine with those patients. You want to try the albuterol, Atrovent route, and of course CPAP with any of these patients might also be helpful. So make sure you know all of the doses for these medications and indications, contraindications, things like that. So that's it. I just wanted to go over those couple things. There's of course a lot more content than that, and that's all covered in your texts. You should be looking at both your pharmacology text and everything that correlates with it in the Caroline Paramedic book. And so, if you're looking over opiates in Module 3 and sedatives, you should also be reading the information on opiates and sedatives in the Caroline book. So, hope you guys are doing that, and I hope this was helpful.